Welcome to the Deep Dive. Today we're diving into a health issue that's really central to our work as pharmacists and, well, for everyone studying pharmacy too. Hypertension, or HTN, is something we encounter constantly, and truly understanding it is, vital for good patient care. So let's get into it.
Absolutely. Hypertension, well, our sources define it as a persistent systolic blood pressure reading of 130 millimeters of mercury or higher,
Right.
or a diastolic reading of 80 or higher, sometimes both, of course. But it's not just about the numbers, is it? It's recognizing and managing this condition that really impacts a person's overall health.
And it's just so incredibly common, isn't it?
Yeah.
The data we looked at shows it's the most frequent chronic disease in the U.S., affects something like 46% of adults.
That's right, nearly half. And the prevalence just goes up as people get older.
That represents a huge number of the patients we interact with every day.
It does. And the really key thing for us, I think, is that hypertension is a major risk factor we can actually modify.
Yeah.
By managing it effectively, we significantly lower the chances of serious cardiovascular events, heart attacks, strokes. That's where our pharmaceutical care truly makes a difference.
Exactly. So this deep dive is really focused on those key aspects of hypertension most relevant for pharmacists and for students learning the ropes. Let's maybe start with the different types.
Good idea. So our sources basically break it down into essential hypertension and secondary hypertension.
Right.
Essential hypertension makes up the vast majority, we're talking about 90% of cases. And in these situations, there isn't one single identifiable underlying cause, but the material definitely flags things like obesity and high sodium intake as major contributors. It's more of a complex mix of genetics and lifestyle, really.
Okay, so that's most patients. But then there's this secondary hypertension. What kind of conditions might trigger that? Spotting those could really shift how we approach things.
Precisely. And being aware of these is crucial. The information lists quite a few potential causes for secondary HTN, things like primary aldosteronism.
Where the body holds on to too much sodium in water.
Exactly. Drives up the pressure. Then there's renal parenchymal disease, renal artery stenosis, narrowing of the kidney arteries, obstructive sleep apnea, that's a big one. Also, Cushing syndrome, thyroid or parathyroid problems. And we can't forget medications.
Right, drug-induced hypertension.
Yes, things like cyclosporine, NSAIDs, some sympathomimetics. And lastly, though it's rare, pheochromocytoma, an adrenal gland tumor. Knowing these possibilities helps us think critically, especially with, unusual presentations.
That's a really useful checklist of potential red flags. Okay, so we suspect hypertension. How do we actually lock down the diagnosis accurately? Our sources really stress proper measurement technique.
Yeah, accurate diagnosis is fundamental. The guidelines are clear. The patient needs to be seated quietly, feet flat on the floor, back supported, for at least 5 minutes beforehand.
Oh.
And using the right cuff size is non-negotiable. The bladder inside the cuff should wrap around at least 80% of the arm circumference.
That's often overlooked, I think.
It is, and it's not just one reading. You need at least 2 measurements, maybe 2 minutes apart. And crucially, the diagnosis isn't made on one visit.
Right.
It requires averaging those readings and finding them consistently above the threshold on 2 or more separate clinic visits. It's about establishing a pattern, not a single snapshot.
Makes perfect sense. It's the trend. Now, the information also brings up home blood pressure monitoring, HBPM, and ambulatory monitoring, ABPM. When do those become particularly useful?
Oh, they're incredibly valuable tools. HBPM and ABPM help confirm the diagnosis, definitely. But they also help us screen for specific things like white coat hypertension.
Where the pressure is only high in the clinic.
Exactly. Maybe their office BP is in that 130-160 systolic or 80-100 diastolic range, even after trying lifestyle changes for, say, 3 months. But their daytime readings at home or via ABPM are actually below 3 to 80. And conversely, they help us catch masked hypertension. That's where the office reading might look okay, maybe 120, 129 over less than 80 after lifestyle mods. But their daytime readings outside the clinic are actually 1380 or higher.
The opposite scenario.
Right. Understanding these nuances is so important for us as pharmacists for proper counseling and helping manage the patient effectively.
Excellent points. So, diagnosis confirmed.
Yeah.
What's the real payoff for treating it? The sources give some pretty stark numbers.
The benefits are huge, and we really need to communicate this to patients. The data suggests treating elevated BP cuts the risk of stroke by 35 to 40%.
Wow.
Risk of MI, heart attack, down by 20 to 25%, and heart failure risk, reduced by about 50%. Half.
That's incredible.
These figures just hammer home the impact of good management and Crucially, patient adherence to their medications. It directly leads to better health, longer lives.
Those stats are compelling. Now, before jumping into drugs, the information rightly highlights lifestyle changes. What specific, actionable advice should we be giving?
Lifestyle is absolutely the cornerstone. The sources are great here. They give specific recommendations and rough estimates of the SBP reduction you might see.
Okay, like what?
Well, weight reduction is a big one, aiming for a BMI in the normal range, 18.5 to 24.9. You can see a drop of 5 to 20 millimeters of mercury for every 10 kilograms, or about 22 pounds lost.
That's significant.
It is. Then there's the DASH dietary approaches to stop hypertension, rich in fruits, veggies, low-fat dairy, lower in saturated fats. It also emphasizes getting enough potassium. That alone can lower SBP by 8 to 14 points.
Okay. DASH diet. What else?
Sodium reduction. The ideal goal is less than 1,500 milligrams per day. That can give a 2 to 8 point reduction. But, even if that's tough, just cutting back by 1,000 milligrams a day helps.
Good practical tip.
Physical activity, getting at least 30 minutes of moderate exercise, like brisk walking most days of the week, that's another 4 to 9 points reduction. And finally, alcohol moderation. For men, no more than 2 standard drinks a day. For women or lighter individuals, no more than 1 drink per day. That can lower SBP by 2 to 4 points.
That's a fantastic toolkit of evidence-based advice we can share. Very concrete.
Exactly. Gives patients real targets.
All right, let's shift gears to pharmacologic therapy. The IMCO classifies blood pressure levels. Can you quickly walk us through those categories?
Yeah.
Helps frame the treatment decisions.
Sure. So normal BP is less than 120 systolic AND, less than 80 diastolic. Elevated BP is 120 to 129 systolic and still less than 80 diastolic.
Okay.
Stage 1 hypertension is defined as 130 to 139 systolic OR, 80 to 89 diastolic.
Got it.
Stage 2 hypertension is 140 systolic or higher, or 90 diastolic or higher.
Right.
And then you have hypertensive urgency or emergency, which is a serious situation with readings over 180 systolic or over 120 diastolic. That needs immediate medical attention.
Okay, those categories give us a scale. But when do we actually pull the trigger on starting medication? And what BP targets are we aiming for?
Good question. The sources lay out specific thresholds and goals, and they depend on the patient's overall picture, their clinical conditions, and their 10-year ASCVD risk score.
Atherosclerotic cardiovascular disease risk.
Right. So if someone already has clinical cardiovascular disease or their 10-year ASCVD risk is 10% or higher,
High risk.
high risk. For them, the threshold to start medication is a BP of 30/80 or higher, and the goal is to get them below 30/80.
Okay, threshold 30/80, goal less than 30/80 for high-risk folks. What about lower risk?
For those without clinical CVD and an ASCVD risk less than 10%, the threshold to start meds is a bit higher, 14/90 or greater.
Yep.
But interestingly, the goal is still less than 30/80.
Ah, okay, so higher start point, same target.
Generally, yes.
Yeah.
And that same lower threshold start at 30/80 and the same goal less than 30/80 also applies to a bunch of specific conditions.
Wait.
Like diabetes, chronic kidney disease, including post-transplant patients' heart failure, both types, HFrEF and HFpEF, stable ischemic heart disease, secondary stroke prevention after a lacunar stroke, and peripheral artery disease.
So for many common comorbidities, it's treat at 130/80. Aim for under 30/80. What about older adults, say 65 plus?
For older adults, 65 and up, who are generally healthy and living in the community, if their systolic BP is 130 or higher, the recommendation is to treat, aiming for a systolic goal of less than 130.
Okay, similar systolic focus there.
Yes, but always considering their overall health, other conditions, life expectancy. It's a more individualized decision sometimes.
That's a very useful breakdown of who needs treatment and what we're shooting for. Now, how do we usually start that treatment? One drug, multiple drugs?
The general approach depends a bit on that initial BP level and risk. For many adults with stage 1 hypertension, aiming for that 13/80 goal, starting with just one antihypertensive medication is considered reasonable.
Okay, start simple for stage 1.
But the sources specifically recommend considering starting with 2 first-line agents from different classes.
Right off the bat.
Yes, right off the bat, either as separate pills or maybe a fixed-dose combination pill. This is particularly for adults with stage 2 hypertension, whose average BP is more than 20 points systolic or 10 points diastolic above their target.
Ah, so for significantly higher starting pressures, hitting it harder initially might be better.
Exactly. The rationale is faster BP control in those higher-risk individuals.
Okay, that makes sense.
Yeah.
And what are these first-line agents we keep mentioning?
The core first-line classes, according to the information we have, are thiazide diuretics, calcium channel blockers, CCBs, and then either ACE inhibitors or ARBs, angiotensin receptor blockers.
Got it. Thiazides, CCBs, ACEs, or ARBs.
Those are the mainstays with strong evidence for lowering BP and reducing cardiovascular events.
And are there times when one of those might be preferred over others based on, say, a patient's other health problems?
Yes, absolutely. The sources give guidance here based on comorbidities. For example, in patients with diabetes, especially if they have albuminuria protein in the urine suggesting kidney involvement, an ACE inhibitor or an ARB is generally preferred initially, though CCBs and thiazides are also acceptable options.
Okay, ACE or ARB, often first in diabetes with kidney signs. What about just chronic kidney disease itself?
Similar story. If albuminuria is present in CKD, ACE inhibitors or ARBs are preferred to help protect the kidneys.
Makes sense. Stroke history.
For patients with a prior stroke or TIA, the recommendation favors thiazide diuretics, ACE inhibitors, or ARBs.
Coronary artery disease.
For CAD, a beta blocker is often part of the initial strategy, usually combined with an ACE inhibitor or an ARB.
Okay. Heart failure, that seems complex.
It is. For HFrEF heart failure with reduced ejection fraction, the foundation is typically a combination: an ACE inhibitor, ARB, or an ARNI, plus a beta blocker, plus a mineralocorticoid receptor antagonist, or MRA, like spironolactone, and often a loop diuretic for fluid management.
A whole cocktail there.
It's guideline-directed medical therapy. For HFpEF heart failure with preserved ejection, fraction diuretics are key for managing fluid overload, and then ACE inhibitors, ARBs, or beta blockers might be used based on other indications or potential benefits.
That's a really practical guide for tailoring that initial choice. Okay, let's dig a bit into these drug classes themselves. Any key warnings or things pharmacists really need to have top of mind? Let's start with beta blockers.
Sure, beta blockers. Well, the evidence doesn't really support them as routine first-line therapy for hypertension alone, unless there's a compelling reason, like prior heart attack or heart failure.
Okay.
We need to be cautious using them in patients with asthma or severe COPD, especially non-selective ones or high doses of selective ones. They can slightly increase the risk of new onset diabetes compared to other first-liners.
Oh, interesting.
And they can mask some hypoglycemia warning signs in diabetic patients. Also, there's some association maybe with depression in certain individuals.
Important points for counseling and monitoring. What about thiazide diuretics? Very common first choice.
Thiazides can increase uric acid, potentially worsening gout. Their effectiveness might drop off if kidney function is severely impaired, say CRCL below 30.
Right.
Like beta blockers, they also carry a slightly higher risk of new onset diabetes compared to ACEs, ARBs, or CCBs. On the plus side, they can help with osteoporosis by reducing calcium loss in urine. But monitoring electrolytes, especially sodium and potassium, is crucial.
Good rundown. ACE inhibitors and ARBs. Used very widely.
Key things here. They are absolutely contraindicated in pregnancy risk of fetal harm.
Critical point.
Also contraindicated in patients with bilateral renal artery stenosis. And like with thiazides affecting electrolytes, we need to monitor potassium levels closely, especially with kidney disease, or if the patient is on other potassium-sparing drugs or supplements.
Got it. The sources also mention aliskiren, the direct renin inhibitor. What's the scoop there?
Aliskiren generally shouldn't be combined with an ACE inhibitor or an ARB, particularly if kidney function is impaired, CRCL less than 60. It's also contraindicated in pregnancy. And importantly, don't use it with an ACE or ARB in patients with diabetes due to increased risks of kidney problems, hyperkalemia, and low blood pressure. Also, watch out for interactions with strong CYP3A4 inhibitors like cyclosporin or itraconazole.
Good to know. Okay, last major class. Calcium channel blockers. Two main types, right?
Right. You have the dihydropyridines, think amlodipine, felidipine, nifedipine. Common side effects are peripheral edema, sometimes reflex tachycardia, maybe orthostatic hypotension.
The ankle swelling? Yeah.
Exactly. These can be quite useful for isolated systolic hypertension, common in older folks, or often as initial therapy in Black patients.
Okay. And the other type?
The non-dihydropyridines, diltiazem and verapamil. These slow the heart rate, so they might be chosen if a patient has hypertension, plus something like atrial fibrillation or stable angina where rate control is beneficial.
Makes sense.
But they're contraindicated if the patient has significant heart block or sick sinus syndrome. And they have more potential for drug interactions because they affect the CYP450 enzyme system more significantly than the dihydropyridines.
That's a really clear, practical overview of the key things to watch for with each class. Now, our sources touch on special patient groups. What about patients who have coronary heart disease alongside their hypertension?
Yeah, in patients with CHD, you want to be a bit careful with potent vasodilators, specifically hydralazine, minoxidil, and also the dihydropyridine CCBs we just talked about.
That is that.
They can sometimes cause a reflex increase in heart rate reflex tachycardia. That increases the heart's oxygen demand, which could potentially worsen angina in someone with underlying CHD.
Okay.
This risk can often be managed if you use these agents alongside a beta blocker or maybe a non-dihydropyridine CCB, which help keep the heart rate down.
Gotcha. What about older adults, 65 plus? We touch on the goal, but any other considerations?
We mentioned the SBP goal of less than 130 for generally healthy ambulatory older adults, starting at 130 or higher. But for those with lots of other health issues, maybe limited life expectancy, treatment needs to be really individualized.
Right.
Weighing benefits versus risks, patient preference is key. And we definitely need to be extra vigilant about orthostatic hypotension dizziness on standing in this group.
Good point. And the SPRINT trial was relevant here.
Yes, the SPRINT trial, mentioned in the sources, is important context. It showed that targeting an even lower SBP, less than 120, compared to less than 140, actually improved cardiovascular outcomes in high-risk patients without diabetes. And importantly, a good chunk of those participants were over 75, so it supports aiming lower, carefully, even in older, higher-risk individuals.
Okay, that's useful background from SPRINT. What about differences in approach for Black patients?
Our sources point out that historically, beta blockers and AC inhibitors might be less effective as monotherapy in Black patients compared to others.
Okay.
So for Black adults with hypertension, unless they have heart failure or CKD with albuminuria where AC ARBs are strongly indicated, the initial recommendation is usually a thiazide-type diuretic or a calcium channel blocker.
Thiazide or CCB first line, generally for Black patients, without specific compelling indications for other agents.
Correct. Beta blockers and ACE inhibitors are still options, of course, if needed for those compelling comorbidities.
Understood. And lastly, any specific considerations for women? Pregnancy, contraceptives.
Yes. Oral contraceptives containing estrogen can raise blood pressure in some women.
Good to remember for counseling.
Absolutely. And during pregnancy, medication choice is critical for safety. Preferred antihypertensives generally include methyldopa, nifedipine, usually extended release, and labetalol.
Okay, those are the go-tos in pregnancy.
Right. And ACE inhibitors, ARBs, and aliskiren are strictly contraindicated due to potential harm to the fetus.
Crucial safety information. Okay, let's talk monitoring. Patient starts a new med or changes dose. How soon do we need to see them back?
The guidance suggests a follow-up, typically within about 4 weeks, to check how well the treatment is working.
A month or so?
Yeah, but sooner if needed, of course, based on their BP readings or if they report side effects. Now, if the response isn't great after optimizing the dose of that first drug and we're sure they're taking it.
Adherence check.
Right. And assuming there's no compelling reason to stick with that specific drug, the next step is usually to add a second drug from a different class while keeping the first one going.
Okay, add-on therapy is common, but what if their BP still isn't controlled, even on multiple meds? That's resistant hypertension.
Exactly. Resistant hypertension is defined as having an office BP still at or above 130/80 while taking optimal doses of 3 or more different antihypertensives, one of which should be a diuretic. And critically, adherence must be confirmed.
Okay, 3 drugs, including a diuretic, still high.
Or it can also be defined as BP is controlled below 130/80, but it requires 4 or more medications to achieve that control.
Got it. So if we suspect resistant HTN, what's the first step?
First, rule out pseudoresistance. That means double-checking the office BP measurement technique is accurate.
Cuff size again, quiet time.
All of that. Then use home or ambulatory monitoring to rule out white coat hypertension. And really dig into adherence. Are they truly taking all the meds as prescribed?
Makes sense. What else contributes?
We need to look for and address contributing lifestyle factors. Again, obesity, high salt diet, lack of exercise, too much alcohol. And look for interfering substances, NSAIDs, sympathomimetics, stimulants, maybe oral contraceptives. And importantly, screen for those secondary causes of hypertension we talked about earlier.
Right, circle back to things like sleep apnea or aldosteronism. Okay, so we've ruled out pseudoresistance, addressed lifestyle, and interfering meds. How do we tackle the pharmacological treatment of true resistant hypertension?
Our sources outline a kind of stepwise approach. First, really optimize the diuretic therapy.
How so?
If the patient's kidney function, their eGFR, is reasonably good, say, above 25 or 30, a thiazide or thiazide-like diuretic is usually preferred.
Mhm.
Chlorthalidone and indapamide have particularly strong outcome data. Chlorthalidone might even work down to an eGFR of 30-45.
Okay, and if eGFR is lower?
If eGFR is below 30, you generally need to switch to a loop diuretic like furosemide or bumetanide.
Got it. Maximize the diuretic first.
Yeah.
Then what?
A common next step is adding a mineralocorticoid receptor antagonist, or MRA spironolactone, or eplerenone, assuming their potassium isn't already high and kidney function allows it.
Spironolactone is often fourth line. Yeah.
It often is and can be very effective. Other strategies include maybe adjusting dosing times, sometimes giving a dose at bedtime helps, or splitting doses of shorter-acting drugs. You can add other classes as needed, maybe a beta blocker if not already on one, or considering direct vasodilators.
Like hydrolysine or minoxidil.
Right, but the sources note that if you use those, you almost always need to use them with a beta blocker and a diuretic to counteract their side effects like reflex tachycardia and significant fluid retention.
Complex management.
It can be, and the information stresses close follow-up. If, after about 6 months of trying these optimized strategies, the target BP still isn't reached, referral to a hypertension specialist is recommended.
This has been an incredibly thorough and, I think, really practical deep dive into managing hypertension from a pharmacy perspective. Just to quickly recap the key areas. We cover the definition, the absolute need for accurate diagnosis, including out-of-office measurements, the very real benefits of treatment, the foundational importance of lifestyle changes.
Right.
And then we went deep into the medications. First-line choices, things to watch out for with each class, how to tailor therapy for specific patient groups like older adults or those with kidney disease, and finally, how to approach resistant hypertension.
Yes, and I think it highlights just how vital our role as pharmacists is. It's far beyond just dispensing. It's patient education on lifestyle, it's collaborating on medication choices, monitoring for effectiveness and side effects, checking adherence. We're integral to optimizing care.
Absolutely. So maybe a final thought for everyone listening. Considering how guidelines evolve and how complex each individual patient really is, how can we, as pharmacists, best use all this knowledge to truly personalize hypertension management and achieve the best possible outcomes for our patients? It's something that pushes us to keep learning, keep collaborating, and keep thinking critically every day. Thanks for joining us for this deep dive.